Annie, I'm going to hand over before I make any more mistakes.
Okay, thanks very much. We've got a patient story at the end of this presentation too, and I'd much rather you listen to Monica than me. So if you just bear with me, I'm going to fly through these slides so that you get the benefit of her story at the end. I wanted to start just with some public thank yous. Some of this work has been involved as working with the King's Fund in a hospital pathways project that was funded by the Health Foundation. And some of the friends from other trusts are in the audience today, so a celebration to you guys too from all we learnt from you. A big thank you to the patients and families that have been involved in this 18-month project, but especially I think to the teams whose passion has transformed hip fracture care at Northumbria. I'm not going to go through all the information that you know already, but just to say hip fracture is common, it happens a lot, and it's generally bad news for a lot of people. Mortality is high, and as many as 20% of people won't make it home, returning to their own home as a result of fracturing their hips. When we started the program, these were our aims essentially that we were focusing on. We wanted to adopt a pathway approach. There was a lot of tension nationally on hip fracture care that we were responding to, but essentially we wanted to drive improved care that was providing exceptional patient experience and meeting not just physical needs after hip fracture, but emotional and informational needs as well. Essential that we had the appropriate infrastructure supporting that improvement work. So we've had a very passionate and engaged hip fracture steering group who have met relentlessly every month for the last 18. We have support from our chief executive as part of that steering group, and we've had engagement from people outside the NHS sector to bring their expertise around the table. This was our launch day. We had as many as 140 people in the room, patients and families coming to describe their experience of care and how they wanted us to change that and improve that. So using a variety of methods already at that start of the project to learn from experts by their own experience of care and what they had to tell us about the gaps in our care. It was a fantastic day. And there was a key moment when the anaesthetist, in response to mortality rate, just stood up in the room and said, why don't we just feed our patients? It set a fire in everybody's bellies, and we walked away with a really important focus of what it is that we were going to change. So has it made a difference? This is measuring and acting and reporting. This is the 2011 National Report on Hip Fracture Care. Our mortality in 2010 didn't make the press, but we were the worst in the country in one of our sites in terms of mortality after hip fracture. We saw a 31% reduction in mortality, a 30-day mortality, a fantastic achievement in response to evidence-based practice of focusing on nutrition. So there was a Cardiff study that has largely been ignored within the orthopedic community, and yet we decided to focus on this and see if it made a difference. The reduction of death rate reported in the literature was around 40%. At the time we were at 31, and we've got that up to 37, so it seems to be mirroring those figures. Timely surgery, accessing surgery as quickly as you can after hip fracture, an important aim that's been talked about nationally and driven. And we were already doing quite well in that area, but in 2011, Wansbeck, one of our sites, was named as best in the country for operating within 36 hours, and North Tyneside the best in the country for operating within 48 hours. Some sites nationally only managing that 9% of the time. Our performance hasn't dipped below 90% since then. You all know a lot about best practice tariff. There was a specific best practice tariff set for hip fracture care around timely surgery, around quick access to orthopedic assessment, and joint assessment, as well as key clinical assessments happening early on. We saw a big change in our performance, going from 2% in April 2010, quickly rising to above 70 in June, and then we hit a bit of a plateau because we were measuring monthly. So we started to measure weekly, and it made the difference. We hit 90%, and again, we haven't dipped below that since that time. The national average is 31%. We weren't just focusing on the stuff that nationally we were being encouraged to focus on. It was about a whole range of interventions across the pathway, the things that were important to patients and families, and equally the things that were important to our staff. And these are just some of them there. We measured relentlessly. We set outcomes against each of these things. And as a team, we met monthly to review how we were doing in all of these areas. This is Hazel. She's a nutritional assistant. We employed 2, and their only role was to feed patients in addition to the extra feeding they were getting on the wards. So quite startling, really, that a reduction in mortality of 30% achieved with an investment of 2 grade 2 staff who go around, offer patients not just what they need to eat, what they want to eat, offer them snacks, offer them cakes, offer them scones in the afternoon. And we also introduced quick and effective pain relief, so access in A&E to a pain block, when 97% of our patients of the 384 interviewed believed we were doing everything we could to effectively manage their pain. Service users themselves designed the information that they wanted to be given. We called together a group of complainants who told us, quite frankly, in the past our information had been inadequate. And together with staff using experience-based design methodology, they came up with new information in a booklet that all of our patients received. We measure patient experience every fortnight on all of our orthopedic wards. These are the core domains that matter most to patients, and you can see the improvements that the teams have delivered over time with respect to that. We share that information, we share it with the public. We've developed infographics that interpret that data and make it accessible to patients and families. And these are the key things that I've learned. I've just had a note that I've got 3-minute countdown, and Monica's story is exactly 3 minutes. So I'm going to skip to that, and I can talk about the things that we've learned in the break. Anyway, she's a lovely woman, and this is what she's got to say.
So there I was lying on the ground, and the ambulance came, and 2 really nice guys got out of it and came and had a look at it. They then put me on a new sort of stretcher, which I'd never seen before, which meant they didn't have to manhandle me, and it slid underneath you literally, and you were lifted up almost hammock-like with no feeling of movement whatsoever. They were taking me to Wansbeck. And I thought, oh no, not Wansbeck. I live in Newcastle. Could you not take me to Newcastle? But they explained they were so near Wansbeck, and I needed to be seen straight away. My husband came home and didn't really know how to tell my daughter what had happened, because she's a real worrywart. And he says she just calmly went upstairs, turned the computer on, looked up Wansbeck Hospital, looked up Mr. Muller, the surgeon who would probably be doing it.